Hello everyone, today we are going to study metastasis. So we will discuss the metastasis in a sequence wise, okay. Then we will look the how all the steps happening and we will end the topic by that, right. So let's start. We will go by the definition of the metastasis. The metastasis are tumor deposits discontinuous with the primary tumor and located in distant tissue. What does it mean? It means that in certain parts of our body or in certain organ we are having a primary tumor, right. Means there is a first originated tumor is located in that organ, and from there it's going to some other parts of the body. It may be other organ, like the prostatic cancer spreads, you can see the metastasis to the bone. So like that this is happening, okay. So we will see how these steps are happening, okay. So here if you will see, there is a only the difference of a letter between metastasis and metastasis. So metastasis is a process, whereas the resulting secondary deposits that is occurring to the other place is termed as metastasis. Now let's see the significance of the metastasis. So a tumor is a malignant, right, and benign neoplasms never metastasize. Remember, the benign neoplasm, those which have a, they are localized, they are not spreading to some other areas. Only the malignant ones, they metastasize, right. So tumor is a malignant, but there are some exceptions, right, like gliomas and the basal cell carcinoma of skin. These are some factual things, okay, just have to remember. That's why I mentioned it in my this slide, that gliomas and the basal cell carcinoma of skin, they are malignant, but they rarely metastasize, right. But the property is that the malignant ones will have to metastasize, they metastasize generally, but only these two are the exceptions. Now what happens when like the metastasis is happening? So obviously it was located right some other place and it is going to some other place, right. So already it has caused the damage to that region, difficulties to the patient, right, and again it's spreading to the other part of the body. So obviously there will be a decrease in the possibility of the cure of the cancer. And the third one is the metastatic spread, that is most common cause of the cancer death. Now let's see what are the factors favoring metastasis. The factors favoring metastasis are poorly differentiated tumor cells, next rapid growth of the tumors, and if the primary tumor is large in size, right. These all three factors will favor the metastasis process. Poorly differentiated tumor cells, right, so they are going to easily spread to the other parts of the body, and if it's rapidly growing, right, its size will increase and it can't accommodate in that area, so it will lead to the dissemination of the tumor cells to the other parts of the body. So often like you will think it's a kind of metastasizing to the other place. So what will be the morphology, how it will look like? So mostly it resembles the primary tumor, okay, and the anaplasia, like anaplasticness, like cells of the origin can't be made out. If you will see, sometimes the cells of the origin, like from where it is getting originated, what was the origin of that cancer, right, we cannot figure out from this malignant site, right. Now the electron microscopy and the immunohistochemistry is needed to establish the contact with the primary tumor, like it's a part of that primary tumor, so we need to do this kind of investigations like electron microscopy and the immunohistochemistry, okay, to establish the link with the primary tumor. So these are the morphological appearance. It resembles like the primary tumor, and anaplasticness will be there. Like anaplastic means the cells of origin can't be made out, like if they will, because they are rapidly proliferating, they are multiplying. So it's very difficult to find like from where they have origin, right, what's the source of origin of their cells. So we use the electron microscopy and the immunohistochemistry to establish the link with the primary tumor, like what was the main source, because already they have been metastasized to the other place, right. Now we will see the pathways of spread. So remember, the pathways of spread is, first is the lymphatic spread, the other one is the hematogenous spread, third is the transcelomic spread, and the fourth is direct transplantation, and the last one is spread along the epithelial lines spaces. So the first one, that is the lymphatic spread. So I have added this diagram. You can see this is the lymphatic pathway of some parts of the organ. Like in the figure A, you are seeing the normal lymphatic flow, right? And that's a draining into the lymph node, okay? And there the further it is draining to the distal lymph node. So, and further it is draining to the subclavian vein. Now in the diagram B, right, you are seeing that here there is a macrophage recruitment and the primary tumor is there, right? So some VEGF, right, vascular endothelial growth factors are like released. So because of that, the lymphatic flow is increased. Earlier it was in the compared to the figure A, it's normal, but here it's increased lymphatic flow, right? And as you can see, there is a dissemination of the tumors, right, tumor cells, and the tumor are draining in the lymph node, right? And here if you will see that there is a SMCs, means smooth muscle cells, okay? And what happens that in the long term, we will see that this smooth muscle cells will get rearranged. So in the figure C, we are seeing that as the tumor size progressing, are progressing, right? The SMC rearrangement is happening, and this it is getting dilated, right? And it will lead to the more and more spread of the tumor cells to the other areas of the body, and thus the organ metastasis happens. Here you can see it's written organ metastasis is happening, right? Now in this one terms you will see that the skip metastasis. What is skip metastasis? So see in this diagram the tumor is here, right? So tumor is not affecting the just next lymph node. It has skipped this lymph node and it has happened here in this lymph node. So this is called skip metastasis. So basically, when the local lymph nodes, right, local lymph nodes are bypassed and the lymphatic metastasis develop in the lymph nodes that is distance from the site of the primary tumor. So these are called as skip metastasis. You can see in the example, right, abdominal cancers mostly will see there is a virtuous lymph node, okay, means the left side enlargement of the supraclavicular node you will see, okay, as in the cancer of the stomach we see the virtuous lymph node, right? Now coming to the retrograde metastasis. So you have seen like how it was in this diagram of the lymphatic. Here you can see how the smoothly the flow is happening, right? There is no obstruction. The tumor is metastasizing, right, to the other organ, to the lymph node also, right? So there is no any kind of obstruction in the pathway. But when there is an obstruction of the lymphatics by the tumor cells, right, the lymph flow is disturbed and the tumor cells spread against the flow of the lymph, and this causes retrograde metastasis at unusual sites. For example, metastasis of carcinoma prostate to the supraclavicular nodes. Now, the second one, hematogenous spread. Before this, I would like to tell you about sentinel lymph node, right? So remember, the sentinel lymph node is the first node in a regional lymphatic drainage that receives lymph flow from the primary tumor. So suppose in this diagram, if you will see, this is a tumor, right? Okay, or you can see the just imagine that this is a tumor, right, primary tumor, right, and from here the flow is going to this lymph node, right? So this is the first lymph node that is receiving the flow from the primary tumor. So the lymph node which receives the lymph flow from the primary tumor, okay, and this is the first node, right? So this will be termed as a sentinel lymph node. So you can see I have made a diagram. So this is the first lymph node which is receiving the drainage from the tumor, right? So this will be termed as a sentinel lymph. And remember, the first line of defense in malignant tumors and the most common site for metastasis is the lymph node itself, right? So before knowing this hematogenous spread, I would like to make your attention towards sarcomas and carcinomas, right? So you will you know already that sarcomas, just I will highlight some important points, that sarcomas are basically originating from the mesenchymal cells like connective tissue, bone, cartilage, fat and blood vessels, right? And the carcinomas originate from the epithelial cells, skin, glands and organs, right? So both sarcomas and sarcomas and the carcinomas, they do the metastasis, right? They undergo metastasis. But the most common route, that is hematogenous spread, we are discussing, the blood route is taken by the sarcomas. Okay, so and but some carcinomas also, like of you will see here lungs, this is B for breast, here the T is thyroid, and the K is the kidney, and you have the prostate, ovary. Okay, I would like to tell about seed soil theory, which comes in the hematogenous spread only, that proposed by the Ewing and the Paget, that this liver, right, lungs, breast, bone, kidney, okay, these all are the good soil for the growth of good seeds. So good seeds mean here we are talking about the tumor cells, right, and these are the organs where they will metastasize and can be successfully grow as a secondary tumor. But there are some like spleen, heart and skeletal muscle that does not allow the tumor metastasis to grow. Why? Why the spleen does not allow tumor metastasis to grow? So there is a concept behind it. The concept is, in spleen there is an open sinusoidal pattern. So open sinusoidal pattern causes the tumor not to stay there for a long time, and thus the adhesion doesn't take place between the tumor cells and the epithelial cells or the endothelial cells out there. Now let's see the features of the homogeneous metastasis. So I have mentioned this, like the systemic veins all drain in the vena cava, and thus from the vena cava it reaches to the right atrium, right atrium to the left ventricle, and from the left ventricle it goes to the lungs, right, through the pulmonary artery. So if there will be the primary tumor located in these areas like limbs, head, neck and pelvis, right, so they will be mostly metastasizing to the lungs. As likely if there is a portal veins like the bowel, spleen and pancreas, right, they all drains into the portal veins, right, and the portal veins drain to the liver. So if there will be any primary tumor, so they will be what, causing their secondary tumor to the in the liver, right. Similarly, if you see the pulmonary veins, right, so the pulmonary veins drains into the left heart, right, and then from the left heart it goes to systemic circulation. So the secondary masses can be formed elsewhere in the body. Now the important point here comes that the arterial spread of tumors. So the arterial spread of tumors is less likely. Why? Because the artery is thick walled and elastic tissue. Everyone knows that. So they are mostly resistant to invasion. If there is a chance through the arterial spread, then it only occurs, right, when the artery becomes capillary. So through the capillary bed, or there is a arterial branches, small branches are there, then only from there, because there the wall becomes little thinner, right. So from there there is a ease for the tumor cells to come out and metastasize. But generally the arterial spread of the tumors is less likely. Understood? So remember this part. Now comes the retrograde spread. So retrograde spread occurs due to the venous obstruction seen in the cancers of thyroid and prostate. There we see vertebral metastasis. So again I will like to draw your attention towards a very important topic, that is the hematogenous spread, right, which we started from the spread of the tumors. First we studied the lymphatic spread, again second we are studying the hematogenous spread. So hematogenous spread we studied in a 4 part. The first part we talked about the systemic veins, that is the features. As the features we talked, what happens when there is a systemic veins draining into the vena cava, and the systemic veins containing the blood from the limbs, head and neck and pelvis, right. Then we saw the portal veins, right, portal veins draining to the liver, and from where they will carry and there is a chances of the secondary tumor growth in the liver. And third, we saw the pulmonary veins, right, draining to the left heart, and how the systemic seeding can happen, right, to the other parts of the body. Also, we saw that the arterial spread of tumor is less likely to happen because of their thick wall and the elastic tissue, but it can happen at the position where the arterial branches are there, and where the artery is like becoming the capillary bed, and so the capillary bed is very easy to come out for the tumor cells. Okay, and we also saw the retrograde spread if there is a venous obstruction, how the thyroid and the prostate cancers are spreading to the vertebral spreading via the vertebral metastasis, right. So these were the some 4 important features of the hematogenous spread which we came across, right. So all you can see here, there is this hematogenous dissemination. This is a gross appearance of the hematogenous metastasis of common sites is the liver, right, and you can see from the intestine the portal blood is going and draining the liver, right. So if there is any tumor, a primary tumor associated with this intestine, right, they will be probably causing the secondary the tumor is the metastasis to the liver. And same here in the case of the of the lungs and the brain and the bone, you can see here, right, and kidney and adrenal gland. Next, I have added also a little gross and microscopic in the case of hematogenous spread, like how it will look like. So I will just go through these points just to here. So I will summarize this as a blood-borne metastasis appear as a multiple nodules in an organ and can grow larger than the primary tumor and may be detected first. Also, they typically resemble the primary tumor microscopically, but can vary in differentiation at different sites due to the local environmental influences. Here you can see the section surface of the lung shows the replacement of the slaty grey spongy parenchyma with multiple form grey white nodular masses, some having areas of the hemorrhages and the necrosis. Okay, coming to the most important, there is a transcoelomic spread. So the uncommon routes of a spread of some cancers by seeding across the body cavities, right, and the natural passages as under like transcoelomic spread. Certain cancers invade through the serosal wall of the coelomic cavity, so that tumor fragments or cluster of tumor cells break off to be carried in the coelomic fluid and are implanted elsewhere in the body cavity. So they are telling that this spread of cancers taking the path of the body cavity or the coelomic cavity, right, and across that they are spreading to the other parts of the body. So if you will see some of the examples, like carcinoma of the stomach seeding to both ovaries, that's already Krukenberg tumor, right. We saw this in the case of breast cancer also. If you see the carcinoma of ovary that is spreading to the entire peritoneal cavity without infiltrating the underlying organs. Okay, so the entire peritoneal cavity is involved because of the carcinoma of ovary, right, metastasis. Now, second is the pseudomyxoma peritonei, is the gelatinous coating of the peritoneum from the mucin secreting carcinoma of the ovary or appendix. Okay, and the fourth one is the carcinoma of the bronchus and the breast leading to the pleura and the pericardium. So these are the some of the metastases that are using the root of that is the body cavity, right, coelomic cavity. So mostly if you see, I am summarizing here that ovarian tumors, malignant GI tract tumors, these two will be affecting the peritoneal cavity, and the lung tumors that is like peripherally situated, right, so they will be affecting the pleural cavities. Okay, now coming to the direct transplantation, it is rare. So what happens that it happens through the surgical instrument uses like a scalpel, needle and sutures also. Okay, or you can see like transfer of the cancer of the lower lip to the corresponding opposite side in the upper lip, right. The fifth one is the spread along the epithelial line spaces. The carcinoma endometrium spreads via the fallopian tube to the ovary, and the carcinoma kidney spreads to the lower urinary tract via the ureters, right. Now the most important topic, right, that is asked in the exam, that is the invasion metastatic cascade. So this cascade includes the beginning of invasion to the metastasis, and remember the invasion is the second most important criteria for the malignancy. So we are dividing this cascade into two phases. The first is the invasion of the extracellular matrix and second is the metastasis. So this metastasis includes vascular dissemination plus housing of the tumor cells and colonization. So there is a difference between the housing and colonization. So housing, you can also tell, is a homing. So what's happened that homing is the process of tumor cells migrating to a new location, right? Whereas the colonization is the process of tumor cells establishing a stable presence and growing in the new location. Means already they have arrived to the secondary location, that is the other place, they have spread it there, but to establish their stable presence, right, and to grow, that is considered as a colonization. So this is very important. So it's divided into two phases. First is the invasion of the extracellular matrix and second is the metastasis. Metastasis includes the vascular dissemination and the housing of the tumor cells along with the colonization, right? Next. So this is what we are going to discuss now. Step 1, invasion of the extracellular matrix, right? So we are dividing this into 4 groups. First is the loosening of the tumor cells. So we will focus on the loosening of the tumor cells. Listen very carefully. What happens normally? If there is a normal cell, right? So there will be the presence of the E-cadherin protein between the normal cells, right? So here if you will see, I have drawn one diagram, right, on the screen. So it's basically, I am telling that this is a normal cell, right? And this normal cell, they are having adhesion between them with the protein. This is the E-cadherin protein, right? So this is the E-cadherin protein. But when there is a cancer, right, in the epithelial cancer, this E-cadherin is lost. This E-cadherin is lost. So what happens that the tumor cells become loose. The tumor cells become loose, right? This is what we are calling as a loosening of the tumor cells. Now the second part is the local degradation or proteolysis of the basement membrane and interstitial connective tissue, right? So to understand this, you have to understand the extracellular matrix is two types. First is the basement membrane and the interstitial connective tissue. Now what happens here? Generally, the malignant tumor cells, right, and there is a stromal cells. The stromal cells means the fibroblast and the inflammatory cells. Obviously this malignancy thing is happening, right? So there will be the inflammation present. So the malignant tumor cells and the stromal cells include the fibroblasts and the inflammatory cells. These two will produce the proteolytic enzymes, and these proteolytic enzymes will degrade the extracellular matrix locally, right, like where they are present. Now let's focus what are these proteolytic enzymes. So these are the Mbbs, cathepsin D and UPA, right? The MMPs are the matrix metalloproteinases, cathepsin D, and the UPA is the urokinase plasminogen activator. So there is a anti-metalloproteinases also. So whenever there is a overexpression of the matrix metalloproteinases, right, then it degrades the extracellular matrix locally. Now we will go into little detail if you want to understand like what happens in real. So focus what I am going to say now. I am saying that what actually happening there in the basement membrane, that is extracellular matrix, means basement membrane and the interstitial connective tissue. What's happening basically there? So there insoluble components are there, right? The insoluble components, they are undergoing remodeling. Right? So remodeling is happening so that the tumor cells can spread away from their primary site, right? Now remember one more thing, that the extracellular matrix is releasing sequestrated growth factor. I am telling sequestered growth factor, right? This sequestered growth factor is very important. We will discuss by taking an example of a metallic metalloproteinases. For example, we are having MMP9, right? So this MMP9 is gelatinase, right? So it will cleave the type 4 collagen. Okay, means it's degrading the basement membrane. No problem at all. It's fun. It's his function, right? Now I told you the extracellular matrix will also release sequestered growth factor. Yes or no? So here again, this MMP9 will also stimulate the VEGF, because VEGF is vascular endothelial growth factor. So this is also released here. Understood? So what I was trying to say is that these proteolytic enzymes not only degrade the extracellular matrix like we saw the MMP9 is doing by cleaving the type 4 collagen, but it also releases VEGF. That's what I want to remember. In the further topic we'll clear this, why this is happening. Now the third part is changes in attachment or adhesion of tumor cells to extracellular matrix proteins. This is very important to understand this part. Now what happens is that normally there is a normal epithelial cells, right? So in their basal surface, so I have drawn a diagram for you. So you are seeing this is normal cells connected togetherly with the ecadrin, right? And in the extracellular matrix you will see I have made an integrin receptor, right? So if there is a normal epithelial cells, right? So at the basal surface you will see an integrin receptor, right? This integrin receptor is for what? It's for the laminin and collagen, right? These are for the laminin and collagen. So this integrin receptor binds with the laminin and collagen, right? And this is present in the normal epithelial cells. Why this? What is the use of this integrin receptor? This integrin receptor helps to maintain the cells in a resting and differentiated state, right? So if this integrin receptor is present in the extracellular matrix, right? So this normal cells, the cell will be there in a resting state and the differentiated state. But once the destruction of the basement membrane proteins is happening, means the laminin and collagen is getting destroyed, getting cleaved, then it generates novel sites. There is a site, we are naming it a novel site, right? And that novel sites will bind to the receptors on the tumor cells and will stimulate the migration of tumor cells. So this I have made a diagram. You can see the normal cells have now turned into the tumor cells, right? So once this is turned into tumor cells, right, you will see the E-gathering is lost between them, right? So cells have become loosened. Now and also they are producing, right, some the like MMPs, okay, and cathepsin D and UPA like proteolytic enzymes. So these enzymes will degrade the basement membrane, and here you have seen that at this position the receptors were present, like, okay, so that integrin receptors we are talking about, it was present there. But what happens is that once it's formed tumor cells now, okay, started the releasing proteolytic enzymes that will cause the degradation of the you are seeing that there is a degradation happening of the basement membrane, and locally they will degrade the basement membrane, right? Now as the basement membrane has degraded, here you will see there will be a formation of a novel site. We were talking about the formation of the novel site. Suppose this is the novel site is formed for the tumor cells, and these tumor cells will attach, these tumor cells will come and attach to these novel sites, yes or no? And once this tumor cells attaches to this novel site, this is called a novel site, this will stimulate the migration of tumor cells. Understood? due to the release of autocrine motility factor, and hence this migration happens of the tumor cell, right, through the degraded extracellular matrix. Now this is a degraded extracellular matrix. Hope you understood, right? And then comes the fourth stage, the locomotion or migration of tumor cells through degraded extracellular matrix. So there is nothing more about it. Already we have discussed this point in the diagram. So just I will rush through the lines that locomotion or migration drives the tumor cells forward through the degraded basement membrane, already we have seen, and the zones of the proteolysis locally that is there in the interstitial connected tissue matrix, right? And this locomotion involves, this is very important line you guys have to remember, that the locomotion involves many receptors and signaling proteins. The locomotion is potentiated by tumor derived cytokines, like we discussed, autocrine motility factor and many other molecules. Migration through this interstitial tissue, right? What happens there? The tumor cells will invade and traverse through the surrounding interstitial connective tissue and ultimately reaches the nearby blood or the lymphatic vessels, right? Cells gain access to the circulation by penetrating the basement membrane of the vessels. So the important things to carry from this is, you have seen how the migration has happened after binding to the novel site. Then it includes many receptors and signaling proteins, one of which we discussed is the cytokine, that is autocrine motility factor, you have to remember, right? And then the migration happens through the interstitial tissue, either to the blood or the lymphatic vessels, by penetrating the basement membrane of these vessels, either it is blood ones or it is a lymphatic ones, right? So let's summarize. Invasion of the extracellular matrix is happening how? So it is happening, first step is the loosening of the tumor cells, that is E-cadherin is there, E-cadherin in normal cells is present, but in a cancerous cell E-cadherin is lost. So the cells becomes, the tumor cells, not cells, the tumor cells become loose, right? And then what happens? The next thing is the local degradation or the proteolysis of the basement membrane and the interstitial connective tissue, right? That we discussed that extracellular matrix is of two types, basement membrane and the interstitial connective tissue. What happening is that this malignant tumor cells and the stromal cells producing proteolytic enzymes degrade the extracellular matrix. Some proteolytic enzymes we saw, the MMPs, cathepsin D, UPA, right? We took an example that here is the remodeling of the insoluble components is happening, and also there is a release of one growth factor, sequestered growth factor. Example, we took the MMP9 is a gelatinase, also cleaving the type 4 collagen, but at the same time it is stimulating the VEGF release, right? And the UP is nothing but the urokinase plasminogen activator. Remember, the degradation is happening locally. Third step, we saw changes in the attachment or adhesion of the tumor cells to the extracellular matrix proteins. Here we saw normally epithelial cells at the basal surface, they are having an integrin receptor, right? And this integrin receptor is binding to the laminin and the collagen. Why? Because this helps to maintain the cell in a resting and a differentiated state. And if it's getting distracted by the MMPs, so this generates novel sites that helps to bind the receptors on the tumor cells to this novel site, and this further stimulate the migration of the tumor cells, right? For this we also draw this diagram to understand this, how the novel site, where the novel site is generated, and how it stimulates the migration of the tumor cells, and how the autocrine motility factor helps in further spread through this extracellular matrix, right? This was the fourth step, right? Locomotion or migration of the tumor cells through the degraded extracellular matrix. Also we summarize this para, what it wants to say, that because the migration is happening across the degraded basement membrane, where we have to remember only the autocrine motility factor, and how it is penetrating the basement membrane of the vessels. It can be either blood and the lymphatic vessels, either it can be or it can be both, right? Now the most important is the second part, right, which we saw here, that the two phases happening: invasion of the extracellular matrix, right, and the metastasis includes the vascular dissemination, housing or homing of the tumor cells, and the colonization. So we'll jump into this remaining the second part. This is the second phase, right? So it's a continuation of the invasion metastatic cascade, second phase. So metastasis, there is the vascular dissemination and homing of the tumor cells, and also we will add here one more thing, that is a colonization. Right? Colonization of tumor cells, right? So first step is penetration of the vascular or the lymphatic channels, that is intravasation into the lumen of the vessels, like the tumor cells, how it enters a vascular or the lymphatic channel, right? It is the blood vessels or the lymph vessels, right? So what happens that the basement membrane penetration of the blood vessels and the lymphatic channels occurs here, right? So who penetrates? The malignant cells, the tumor cells penetrate, right? The next second step is the invasion of the circulation and formation of tumor emboli. Now the tumor cells are there in the circulation, right? Either it is a blood one or it is a lymph one, right? So not all the tumor cells is going to survive, right? Only few one is going to survive. That those who can bear this all stresses, like shear stresses, or they are saved from the innate and the immune defense, right? They are saved from the process of anochisis. So then only some tumor cells are survived, and those tumor cells may bind with the platelet, or they can bind with the active coagulation factors over there in the blood, and they form an aggregate. And those only tumor cells survive who has formed the aggregates with the platelet or with the active coagulation factors, and their implantability is possible. So I have mentioned one part, that is anochisis, right? Anochisis, right? What is anochisis? So remember, whenever the cells lose their adhesion, right, either it is a normal cell or a tumor cell, so apoptosis is stimulated in those cells, right? So you will say some of the tumor cells are because many tumor cells doesn't go under apoptosis, right? But yes, it's true that tumor cells doesn't undergo apoptosis. But few tumor cells can undergo anochisis. That is, the apoptosis is stimulated in them due to the loss of the adhesion. Now coming to the third point, that is the transit through the circulation. So they pass through the circulation, and the fourth step is the arrest within the circulating blood or lymph, right? So they get arrested within the circulating blood or lymph. So what happens here, the tumor cells, those who have survived, now it's a time for their implantation, that is, they bind with the endothelial cells and adhere to them, right? The fifth one is the exit from the circulation into a new tissue site. This is very important. So this depends on some of the factors, because this is going to be the secondary deposit. The primary was there from where they have been coming from, right? Now this is the time where they are going to be a secondary tumor. So there should be some favorable conditions, right? The first one is the anatomic location, and the second one is the vascular drainage of the primary tumor, and also the tropism of the tumor for the specific tissues, right? These three factors decides the site, the new tissue site, the site of the secondary tumor. And do you know how they will do this invasion steps, the way they invaded, right, earlier? So that these steps will be the reverse of that invasion. So we are not going to detail of that much, but just remember here that invasion steps will be reversed, and thus they will enter the new tissue site. Now the sixth one is the formation of micrometastasis. And the micrometastasis, like the prostatic carcinoma to the bone, like bronchogenic carcinomas to the adrenals and to the brain, and like neuroblastomas to the liver and the bones, right? So this is nothing but metastasis is basically small clusters of the cancer cells, okay, that have broken away from a primary tumor, right, and spreading to the other parts of the body. Remember, so this is the metastasis, right? So this can also remain dormant for many years, understood, and they can grow also and form a larger metastasis, okay. They can be resistant to the treatment also and can cause further dissemination. So this is a very important step here, right, because this is reaching to the brain also, right. So very important step, right. Then comes the angiogenesis, right, like there will be the formation of the blood vessels, the blood supply, right, providing the nutrition to the tumor cells so that they can grow much more, right, rapidly, and they can grow more nicely, grow in size. So angiogenesis happens, right, and this micrometastasis, right, and this micrometastasis causes a local growth, right, local growth into, and it turns and then turn into a macroscopic tumor. Remember, so how this again grows into a secondary tumor? These are the steps, right? What we studied is that first they are penetrating the vascular and the lymphatic channels, right, by the tumor cells. Obviously they are invading the circulation, forming a tumor emboli. Many are getting destroyed by the severe stress, innate and immune defense, or those who are survived, they are surviving only which are getting bind with the platelet or the active coagulation factors. These aggregates only survive and have the chances of implantability. Some transit through the circulation and some arrest within circulating blood or lymph, right, and those who get arrested with the arrest and they adhere the endothelial cells, means they got bind to the endothelial cells, and thus they exit the circulation into a new tissue site. And here also there are three conditions that will decide the site of the secondary deposit. That is the anatomic location, the vascular drainage of the primary tumor, understood, like we discussed earlier, the hematogenous spread, right, how the portal vein, the carrying blood from the intestine, if there is an intestinal primary tumor, that can lead to the liver, secondary tumor in the liver, right, that all depends, understood. And the tropism of the some certain tumor cells are tropic to the some certain parts or organ of our body, so that also matters a lot, right, they love that region more, like that kind of thing. And then this, how it happens? So this happens, all the investigation steps that we studied, that the reverse happens of that all steps. And now the formation of the micrometastasis. So obviously this micrometastasis will happen, like this is nothing but a small cluster of the cancer cells they will start depositing right there, okay, means those who is coming from the primary tumor only, okay. And then there will be the angiogenesis, the blood formation, blood supply, blood vessels formation to the tumor will happen, will take place, and then the local growth of the micrometastasis in the macroscopic tumor will take place. The most important part to note is that we discussed the some soil theory, right, we discussed this seed soil theory, right. So this seed soil theory, so remember the good soil we discussed, right. So we here that some organs are there in our body, some tissues are there that may be unfavorable soil for the growth of tumor deposit, and the examples, right, are spleen and skeletal muscle that we discuss here, that the spleen, heart and skeletal muscle, right, so they are unfavorable soil for the growth of the tumor, so metastasis doesn't happen here usually. So this is a table I have taken from Ramdas Nayak. You can see here that in lungs we are seeing the metastatic tumor, right. So this is coming from the carcinoma of the breast. So primary side was the carcinoma of the breast, right. Like this, some of the metastatic tumors in the organ I have mentioned here, right. In this table you can see, and you can read once if you are liking to read it, right. Next, so I have taken this diagram from the Ramdas Nayak. So here you can see the diagram A is telling us about the normal epithelial cells. There is a normal cells, E cadherin is there in between them, right, and you can see at the basal surface there are the receptors in the basement membrane. There's obviously the integrin receptors, right, and next this is the interstitial tissue, right, this together they are calling it as a extracellular matrix. So what happens that suddenly these normal cells, due to some external stimuli or something, the pleomorphism takes place, and there is the hyperchromatic nucleus, the features for them tumor cells, right, and the formation of the malignant tumor starts taking place. Then what happens that this you are seeing here, the E-cadherin molecule is getting lost, right, because of the adhesion is lost between the cells. So the loosening of the intercellular junction starts taking place, right. So the tumor cells is now loosened due to the loss of the E-cadherin. Then what happens the next in this D diagram, now this having some collagenase, right, and this is something we talked about the MMPs, UPA, right, that all starts releasing from these, and also from the this we have talked about the fibroblast, right, the stroma things and all. So they all starts releasing this and degraded the basement membrane. So the local degradation of the basement starts taking place over here. And the second, the fifth one is the E number diagram we are seeing here, that they are telling that there is this is the attachment of the tumor site. They are writing here to the extra. So this is nothing but a novel site that is formed here, and then comes the autocrine motility factor, and because of this the migration of tumor cells starts taking place, right. And if you'll see, this is the vascular dissemination, homing, right, and also the colonization, right. So what happens here, this is a primary tumor, they have invaded the basement membrane of the tumor cells, right, and the intravasation happening, then their interaction with the host lymphoid cells, right. Obviously here you've seen the tissue distractions, obviously from there have come and reached these vessels, right. This all is the basement membrane thing. Now they are traversing this, right, and traversing this, and what happens, the tumor embolus have been formed, right, and these now have reached to some their favorable side depending on the factors, the anatomical side, right, and many things, the blood supply and their tropism, right, and then they are coming out in the same manner. The reverse of this thing which you have seen here, the degradation of basement, same things a reverse step will take place over here, and this is the happening here, the micrometastasis. Now this angiogenesis will happen. You can see the blood vessels formation, this place is taking place, right, and you can also see how this is now growing into a bigger size, like a macroscopic tumor, yes or no. So after tumor embolus, the extravasation of tumor cells on metastatic side, you can see here the metastasis happened, now angiogenesis happens, and the metastatic tumor is there in front of you guys. So I am here Aman signing off. This was the metastasis topic. I thought that it will be completed within I think 20 minutes or 25 minutes, but sorry for that, it took me 47 or 48 minutes to complete this. But I hope this will help you whenever you will try to understand this topic at any time. You can watch it as a 1.5x, no problem, but once go through this, I think it will help you, and you can suggest if anything mistake is there in this video, you can write in the comments. I will try to change myself in the next video, right. Thanks for watching this. See you, goodbye, take care.